Just like we did yesterday, pregnant patient for anesthetist. Today we will do pediatric patient for anesthetist. Okay. So how many of you do pediatric anesthesia? Anyone who is regularly doing pediatric patients? Any one of you? Long time ago. Okay. Any Abdul Sami, you can just speak out. Any experiences, anything, what you can think that you have a pediatric patient. What things come to your mind?
Assalamualaikum. Good evening, sir.
Yes.
Yeah, during my training, the first phase of dinner was a long time. So just we started from the pediatric anesthesia. So if you will see the pediatric anesthesia, there are a lot of different from the analytical, from the physiological, from the drugs and dosage, and all this. So basically, it's the different from the adult. If you are going to deliver the tidal volume, dosage of the drug, and even the recovery sometimes. So this is what I remember.
Okay. Okay. And anyone else? So actually, if I just add on to what you told, that actually first difference will be that history, the patient will not be telling, the parents will be telling, number one. Okay. And number two, there will be issues related to, because here I will be discussing my words will be about starting from neonate to a kid. Okay. So there will be some concerns which will be neonates. There will be some concerns which will be in later age group. But I'm just trying to have a consensus of, if you have a small adult, what will you do? Okay. So one of the important thing will be that parents will be giving the history, and there will be issues related to consent. These consent issues are asked more so if you are appearing in some international exams like British exam or Irish exam. There may be a questions which are related to the consent issues. Okay. So other than that, if you just think about problems you will be facing in the before you start anesthesia. Okay. So you will have problems with IV lines. Okay. The IV lines will be difficult. Then there will be stranger anxiety. So the baby will be crying. Okay. Then you need to have special environment in the OR with reference to temperature, with reference to this one equipment. Okay. Drug doses, small syringes. Okay. In equipment, everything will come in from airway to BP cuff to monitoring to everything. Okay. So there will be some, you will be preparing for it. Otherwise there will be some problems which will be more common in pediatric age group. Like, for example, if you have a neonate, you always have to rule out any congenital anomaly. Okay. Congenital anomaly specifically with reference to cardiovascular system. Okay. So you can anyone tell what question you should ask the mother that just to rule out if the baby has some congenital cyanotic heart disease? What question you should ask?
Is your baby having cyanosis or a color of change?
Yes.
During the cry?
Yes. And of course, like in any, actually this is true for any other problem as well. Is the baby feeding nicely or not? So this will be one thing. And the development landmarks and cyanotic that does the baby gets blue when the baby cry. So this will be a good sign. to get the information that whether this patient has something. Of course, this is not a very good elaborated sign, but in addition to the landmarks, the landmarks means the time when the baby should sit, the time when the baby should stand, the time the baby should have, like all landmarks, teeth eruption, and all or everything is getting normal or not. If there is any delay,
Like like milestones, sir?
like milestones. I am sorry, I am using the
Oh,
wrong word, milestones, not landmarks,
oh,
milestones. Apologies. Thanks for
no,
correcting
no,
me.
it's fine, sir.
Okay.
No, no, no
So
problem, sir.
yes. So similarly, like some other things. Just think about it. The common surgeries for which patients are coming, actually they may be the congenital problems. Like for example, some orthopedic correction. Okay, like for fall fractures. Okay, like if the patient has some developmental problems, like just like milestones. So this may be coming for MRI, okay, or any investigation to have the diagnosis. Okay, then what else the procedures can be? Just think about it. What will be the common procedures in pediatric? Like for example, there may be hernia. Okay, there is circumcision. Okay, there is neurologically there is hydrocephalus. So they are coming for VP shunt. Of course, any surgery can occur in pediatric patient, but usually what you see, just think about one by one and you will come to know. In ENT, this the adenotonsillectomy is very common. Tonsillectomy, adenoids. Okay, and
Meningomyelocele.
this
These are the
yes,
yeah, these are the elective cases. Emergency. Usually the kids they are present with the foreign bodies.
Foreign body.
In
Yes,
just yeah, it's
foreign
very common
body,
in the pediatric.
foreign body, testicular torsion, and undescended testes, and this one, this urology procedures like pyeloplasty. Okay, so like of course this is there is a long list. If you have a patient with sickle cell disease, so the patient might have cholecystectomy even. Okay, or infarct anywhere. So this will be with reference to actually hernia. I wanted to tell obstructed hernia as well. Okay, so you must be thinking that your challenges will be according to that, of course, that surgery as well, like in tonsillectomy or anything. So the basic problems for you in will be that sometimes it's difficult to evaluate the patient because you are relying on the information being told by the parents, and there may be communication problems. And so this is one thing, that you are not getting information directly from the person. So there may be a discrepancy which may be there, but of course the small babies, the mothers are just like a mirror of the baby. So of course we are doing like that. Okay, so what else now? For example, now yes.
Yeah, sorry, sir. These are the general cases we are facing all the day, because I have done the general as well as cardiac anesthesia. The problem here sir, is the cardiac anesthesia with the patient coming with the VSDs, ASDs, and
Yes.
TOF patients,
Yes.
tautology of flat. That is a very different from the general anesthesia.
Yes.
And there are a lot of things. Yeah.
You know, I have worked 2 years in cardiac anesthesia in National Guards. So I know that you know the all the problems which are written in that our holy book of Morgan Sharif, the chart with all cyanotic and acyanotic heart disease with increased pulmonary blood flow and decrease everything, like total anomalous pulmonary circulation, and the aortic switch procedure, Glenn procedure, Fontaine. There are so many procedures, but generally I'm just for a journal anesthetist, or for a general understanding for a resident, the cyanotic heart disease will be one thing. Of course, it's a tip of iceberg. There is so many things which will cover which will be coming under that roof. Okay, so along with the, because I missed that point, small thing, that there are some other congenital anomalies like tracheoesophageal fistula, congenital diaphragmatic hernia, okay, infantile pyloric stenosis, okay, and what else, these gastroschisis or omphalocele. Okay, so of course,
Tracheoesophageal fistula.
yes, this is TOF, tracheoesophageal fistula, esophageal atresia. So these are the things which you can have when in a form of vetter or vectral, like in a combination it will come. Okay, so only this gastroschisis actually is a thing which is usually isolated. Okay, so the challenges, the one of the challenges, like we told, is about the journal evaluation of the patient. Okay, so now I'm just trying to chalk out the problem. Journal evaluation of the patient, consent issues, anxiety, anxiolysis is a big problem. Okay, IV lines is a big problem. Then induction. Okay, so if you for example, if you don't have IV line, you will go for inhalational induction. And inhalational induction, you will have, like, I have a question that if you have a patient which does not have IV line and you are trying to have inhalational induction, should you or can you pass LMA before taking IV line? Yes or not?
No, sir.
Why?
Yes, sir, we can pass.
Dr. Humera, your answer is wrong. Yes, why not? The person who said no, why not?
Because when we pass LMA, first we do IV induction agents without IV line. How we use induction agents, the like propofol or
No,
other things. First of all,
in the kids, it's in the kids, it's a Dr. Murma, it's very different. Yani, you can proceed with the inhalation.
Without inhalation, sir, without inhalation, how we can pass without any sedation? How we can pass LMA?
Inhalation with a bag.
First,
No,
okay. Yes, sir.
just a second. Just a second. Let me ask my question again. My question is that you are doing inhalational induction, and when you are doing inhalational induction, patient is deep now, and now someone is trying to have IV line. My question is that at that time, can you put LMA, yes or no? Now you understand my question, Dr. Asma?
Yes, sir.
No, sir, no.
No, sir. My answer is no.
Why? That's what
No,
I'm trying
I cannot
to ask.
induce.
Just a second. I
cannot do LMA.
Yeah, why? That's my question.
Because this is a maybe excited stage of anesthesia. It may be triggered for laryngeal spasm.
Very good.
Exactly.
Okay, so this is the reason that at that time, if you are just, maybe patient is not responding to the prick, so that the patient has achieved MAC, but not MAC bar. Can anyone tell me difference between MAC and MAC bar? What is difference between MAC and MAC bar? Yes, please. Actually, for doing any airway manipulation, actually you need MAC bar. That is blunt adrenergic response. MAC is MAC. MAC is in which 50% patients will not respond to surgical stimulus. So it's taking IV line is, you can say, sort of a mini surgical stimulation. Okay. So, but you cannot do it because you don't have any IV line. Patient can go in laryngospasm, and if you have laryngospasm, you cannot give any medication, you cannot rescue, you cannot ventilate, and you can have a disaster. Okay, so never ever try to pass LMA till the time you don't have IV line. The patient may be breathing spontaneously, patient may not be responding, you are having multiple pricks, but don't go for airway manipulation. Okay, so the message for all of you is that one. Okay, so this is a very important thing. What are different like techniques by which you can take IV lines in pediatric patient? One is vein visualizer.
Sir, what is the sorry, sir. Sir, what
Yes,
is
yes.
the value for Mac bar? How much Mac amount is for Mac bar?
Around 2 to
1.3
3.
Mac or
No, 2.
2 Mac?
2. Yes. Okay, 2 to 3 Mac. Okay. Yes, actually your voice is distorted. So vein visualizer, ultrasound. What else? Intraosseous.
For
Rafe,
it would be
Rafe,
4%. Okay, sir. Okay, sir. Thank you.
Rafe, I apologize. I maybe I understand your point. I will just explain to you. This is a very big. I have discussed before one time,
Yes, sir.
many months ago. I will try to have another session on inhalational induction. You know, what is MAC? Now let's clear this point in 2 minutes. What is MAC?
Sir, Mac is the
Okay, I'm sorry, your voice is distorted. I will
amount
explain.
of minimum
Rafe,
amount
apologize.
of inhalation anesthetic.
I'm sorry, my Rafi, I will have to mute you. Your voice is not coming. I will explain to you. Actually, the reading of, for example, 2 for sevoflurane, 6.6 for desflurane, this is the minimum percent which will give you 1 Mac. And when you open the dial at 6 or 4 or 2 or whatever, it doesn't mean that you will achieve the Mac immediately. It will take some time to achieve the Mac. And only by the dial you cannot tell that I'm giving 1 Mac. Okay, if you take sevoflurane and put the dial at 1 on 2%, it doesn't mean that you have achieved 1 Mac. Okay, it will be depending on the minute ventilation, it will be depending on flow, it will be depending on uptake, or a number of factors by which will define the inhalational agents achieving Mac value. Because in Pakistan, unfortunately, we don't have the usual it's available in some of the setups, but we don't have this availability in all our hospitals, and we don't have agent analyzer. So you can only tell about the Mac value, that it is either it is 0.5 Mac, or it is 0.8 Mac, or it is 1 Mac, or it is 2 Mac, if you have the agent analyzer. Okay, in the agent analyzer, it will be telling you that of course this is not 100% accurate, but they ask for the year of the patient, age of the patient, and then they will calculate from the data which is feed in that setup, and it will be giving you whether it is 1 Mac or 2 Mac or 3 Mac. Okay, so maybe your dial is at 12 for desflurane, for example, and you have low flow anesthesia, you are only giving 500 ml, and maybe you have only achieved Mac of 1.2 by you have opened the dial 12, because all other factors will tell you that how much Mac you have achieved. So whenever we are saying 2 Mac or 1 Mac, it means the whole of the picture of the situation, the level which is being achieved, and it is only calculated through agent analyzer. I hope I answer your question. Okay, because opening the dial at 2% for sevoflurane or 1% of isoflurane doesn't mean that you have achieved Mac. Okay, I hope I answered the question. Okay, so what are different ways to like with different way for getting IV line in pediatric patient? So you might need ultrasound will be difficult, vein visualizer will be difficult, intraosseous line will be one option, but usually where we don't try in the adults, you might get in pediatric patients like in the head. Okay, like on if you don't succeed anywhere, then you might need to go for intraosseous, or you can have femoral. Okay, because this one will be difficult. Even getting taking the lines in the neck will be quite challenging, because of very short neck and short vessels, compressing, and even use of ultrasound will not be very easy. So if you see a very cute baby, that cute baby will not be very good candidate for anesthetist. So IV lines is a big problem. Okay, and with reference to airway management, because of the differences, physiological if anatomical differences, patient will get hypoxic very early, and patient, if get hypoxic, patient can have cardiac arrest very early, because there will be very less reserve, there is high oxygen consumption, there is a low FRC, and combination everything, patient will desaturate very quickly. And because of overgrowth of in these patients, sometimes they are nasal breather, so all this make airway very difficult. Airway will the larynx will be anterior, so it will be difficult to have laryngoscopy. The tube size calculation will be a challenge. Usually the formulas which we practically sometimes you face problem, and there is always a debate between whether you should use cuffed or uncuffed endotracheal tube. So you can use, before there was a concept that you don't need to have cuff endotracheal tubes in babies, but actually now it is preferable, it is better to have, because it gives a good seal and there is no problem. And because the volume, the cuff now we have in the endotracheal tubes, they are low pressure cuffs. Okay, so it is not creating any problem with the development of sore throat postoperatively. Okay, and the tube may pass through the cords, but because it is funnel shaped, so maybe it is stuck later on. So you have to be careful about handling these things. If you are doing laryngoscopy, you can easily damage the tooth, you can easily damage the mucosa, because it's very fragile. So with reference to airway, you have to be very careful. Okay, so this is one thing. Then with reference to pharmacology of the medications and drugs and everything, usually because volume of distribution is high, so initial maybe you need increased doses, but because liver and kidneys are not mature, so you might need to reduce the maintenance doses. Okay, otherwise if you have a baby, a premature baby, you will be avoiding any medication which can cause apnea. Okay, like for example, you will avoid morphine, or you will avoid any medication which can cause respiratory depression in this patient, and you will have apnea alarm. There is apnea monitoring alarm. Okay, apnea monitoring you will be doing. So similarly, induction agent, all you can use. Of course, you will use either SIVO or halothane. Okay, and you will not use desflurane or isoflurane for induction, because it will be irritant. Okay, but if you remember one thing, this is irritant, but the thing is that all these have dose dependent bronchodilation. Okay, so don't be confused that desflurane and isoflurane will not cause bronchodilation. They will cause bronchodilation. Okay, but they are irritant. So for induction, desflurane and isoflurane is not a good choice. Similarly, because desflurane does not have any metabolism, it's least soluble, and so recovery is quick. So that is associated more. It is happening with sevoflurane as well. But with DES, there are the incidence of emergence delirium. In some books, you will find sevoflurane. In some data, you will find desflurane. So actually, both of them can cause emergence delirium as compared to halothane or isoflurane. Okay, so this is another point about inhalational agents. NSAIDs, actually, in younger babies, it is better not to avoid NSAIDs. Okay, and paracetamol, you can give either IV or even rectally. It's safe, 10 to 15 milligram per kg. Okay, and other opioids, you can use fentanyl, you can use remifentanil. Like there is very important point related to fluid administration. So actually, before there was a concept to use Paeds solution. Just a second, let me. I have agenda. Yes. Okay, so you know about it. Single breath induction with sevoflurane. It's a crap concept. It is only drama by the pharmaceutical companies. You will never achieve. Okay, can I explain what is MAC bar? Mahnur, have you understood MAC bar or not? I just saw the messages. So I hope you are clear now. If you are not clear, you can ask. Okay, anyways, So regarding the fluid, because before there is actually, it's available in all the hospitals, in not all the hospital, in some of the hospital, and in periphery, the terrible peat solution, which is 10% dextrose water with 0.18% normal saline. So it's a crap solution. Its name should be crap. Okay. So it's terrible solution. These babies, young infants, they are already sodium losers. So they are already tend to have hyponatremia. And you are giving a terrible 0.18% solution, which will cause even further hyponatremia. You are giving 10% dextrose, which cause diuresis. So this is a rubbish solution. I don't know who was using it. These days, isotonic solutions you have to use. You can use ringer lactate. You can use normal saline. Okay. Ringer lactate or plasma light is a better solution as compared to normal saline. Okay. So you will be calculating according to 4:1 formula. Okay. And then you will be having this maintenance fluid. One will be deficit. It's very important to assess the dehydration and assess the blood volume. Okay. Because maybe in normal patient, you are not concentrating on 100 ml blood loss, but 100 ml blood loss will be significant for a baby. So you have to, for our all patient, around 85, if it is premature, even more than, but around 80 to 85 ml, you will find different readings according to the age, roughly around 80 to 85, or even up to 90 ml if it is premature, even 90 to 95 ml per kg, say. So you have to calculate it, and then you will be calculating the allowable blood loss. Okay. So you will find a number of formulas for that. I don't have time for that thing at the moment, but you have to calculate the allowable blood loss. And then the point is that you can give maintenance with 0.45% 5% dextrose saline. Okay, the half. But if you are expecting hypoglycemia, with the normal fluid, you can add 10% if you want. Okay, especially in premature babies. They don't have the dextrose, and these babies are have tendency to go in hypoglycemia. Okay. So these are calculation, assessment, and very important thing is to calculate the dehydration. Usually, what will be the difference? That usually you, in normal patients, you will have tachycardia and hypotension, you will not find. Okay. So you have to be very careful. You have to assess the fontanelle, the skin turgor, the mucous membranes, and if the patient is awake, for example, because this scenario, they will be asking you with reference to gastroenteritis in pediatric patient or infantile hypertrophic pyloric stenosis, because in that patient, you need to resuscitate and correct the dehydration before proceeding for anything. Okay. So assessing the dehydration, usually you will find in a number of books 1 to 5% and 5 to 10% and more than 10% dehydration. Okay. And usually the correction is that 10 percentage multiplied by this one body weight. Okay. Like for example, if you have a 10% dehydration, I'm sorry, I've made a crap. So it is 10 multiplied by percentage dehydration multiplied by kg. Okay. So if you have a 10 kg baby who has 10% dehydration and weight is 10 kg, so it will be around 1 liter. So this will be a just guide that you might need to give even fluid up to 1 liter in that baby. But of course, you will not give it immediately. Maybe you will give in first half an hour or 1 hour, and then you will see the response, and you have this goal directed fluid therapy. Okay. You should have slightly higher urine output in neonates and pediatric patient, even up to 2 ml per kg per hour. Okay. So you will be assessing the clinical condition parameters, but the thing is that it will not respond much with reference to tachycardia. Okay. So this will be the difference. And as I told you that these babies are dependent on heart rate. So if the patient goes in bradycardia, they will have cardiac arrest. So it is very important to respond to the heart rate, because their cardiac output normally is not maintained by, so they have heart rate dependent cardiac output. So you have to maintain the heart rate. Okay. So few things are left with reference to maintenance, analgesia. Dexmedetomidine is being used in pediatric patient as well. Lidocaine, IV lidocaine, you can use in certain scenarios. It is very important to calculate the local anesthetic volume and concentration and dose. Okay, but it's very, very tricky because 2 milligram per kg of bupivacaine and, for example, 3 to 5 milligram per kg of lidocaine. And when they are giving caudal block or things like that, it is very difficult to calculate the correct doses. Okay. So remember, at any route, you don't have to give more than 2 milligram per kg and more than 3 to 5 milligram per kg of lidocaine. So this is the bottom line. Whatever dose you are giving, and you should be knowing that if it is 0.25% of bupivacaine, it is 2 milligram per kg per ml. Okay. And if it is 0.5%, it is 5 milligram per ml. So that's how you will be calculating. Even in Armitage regime, if the weight is too low and you need to give more volume, you have to reduce the concentration. Okay. Like for the example is that, for example, if you have to give 1 ml per kg, 1 ml per kg of 0.25% in, for example, 2 kg. Okay. 2 kg baby. So it will be 2 milligram. Sorry, 4 milligram is the safe dose for this patient. Okay, 4 milligram, but you are giving 5 milligram here. So you need to decrease the dose, because if you give 2 ml, because 2 ml per 1 ml per kg means you have to give 2 ml. Okay, so if you are giving 0.25%, so you are giving 5 milligram. The dose, the safe dose is 4 milligram. So you cannot cross it. So you will have to reduce the concentration. Maybe you can give 0.2% or even 0.1% in that scenario. Okay. So this is important. You should try to use 3 cc or maximum 5 cc syringes, because if you are using big syringes, the cannula which is being used is small, so it can bulge. So this is one thing. And another thing, that maybe in other patient, small bubbles of air is going and you don't bother. But if you happen to inject even smallest of volume of air in a patient with residual shunts, so it can cause paradoxical air embolism. If it is right to left shunt, it can cause embolism, paradoxical air embolism. So it is better to use diluted, and it is better to use smaller syringes in pediatric patients rather than using 10 or 20. You can use, it's not like that you should, but you should be careful. And it is better to give 3 cc rather than 20 cc. Okay. Okay. So any other point? Blood transfusion. Now, of course, transfusion triggers will be a little tricky and a little different. We will actually, I have discussed before, usually we are transfusion triggers are a little higher because there is physiological, according to the physiological status, yeah, usually around 6 to 7 to 8 months, I think there is a physiological anemia. Okay. So after that, you have to be very careful about the blood loss. You have to calculate the allowable blood volume, and you have to repeat ABGs, and then you will be giving the blood, or for example, 10 ml per kg, for example, 10 to ml per kg, like that. Okay. Okay. So actually, this is just like if I just tell you the summary that you have a pediatric patient, so you will have these challenges before bringing the patient to OR, and you have to make that careful positioning. Tissue will be very fragile. Even, for example, if you have put the bear hugger, and you can directly, for example, if it's too hot, even that can create problem. The babies, they don't have the shivering mechanism. They are dependent on the brown fat. Okay. So I think I have just in this quick discussion, I have tried to cover some main important points which you face in pediatric anesthesia. Any questions or any comments, anything, any clarification?
Sir, my question is, according to new articles, pure 0.99% normal saline is given for resuscitation in even neonates.
Yes.
I discussed this with the HOD of a children hospital.
Mhm. Yes, I told you that resuscitation, it is 0.9%, or you can give ringer lactate or plasma light. Like you have to give isotonic fluid. Okay.
Even
But-
during anesthesia, she insisted that we use 0.9% normal saline during neonatal surgeries.
Remember one thing, Tayyab, we cannot quote, like, for example, you cannot quote me anywhere and you cannot quote her as well. Okay. The thing is that sometimes you just have to follow remember, practically, you can give even tap water. If you don't kill the baby, if you have experience, you can give tap water. Okay. But thing is that
Okay.
when we are talking on academic forum, you have to be liberal. You should be knowing what are your limitations. The point is that we can give 0.9% normal saline, okay, and we can give ringer lactate and we can give plasma light. It is not good for every patient all, because, for example, I can explain to you that if the patient has if the patient has electrolyte imbalance other than dehydration, so it is better to give ringer lactate or plasma light, because it will have other ions as well. Normal saline will not have potassium. Normal saline will not have lactate. Okay.
Okay.
So this is the only thing. But for correction,
Right.
you are she's absolutely right that it is better, because 0.9% saline will have more sodium. Okay. It will have 150.
Yes. Sir.
So initially it is
Okay.
good. So that's the point. Yes, Oppo A12, you raise the hand. You want to ask any question? Okay.
Only, sir, there
Yes.
one thing I will add here only, that is the only from the analgesic point of view. When
Yes.
you are going to extubate the patient, you have in Pakistan, I'm speaking, that you have the only limited option. The baby is going to cry, and you have the only suppositories there, either paracetamol or the diclofenac. I don't know it's available remifentanil and other things there or no. I remember that what we use sometime will the not a generic name, it was Kins, the name was the Kins.
Nalbuphine.
We were used to be, yeah, albifin, yeah, that's correct. So there is
Sir,
very
there
limited
is a-
options and for the analgesia for the children actually.
Yes.
So
So
we can,
we can give, actually we can give nalbuphine as well. We just have to be, because nalbuphine is not an opioid, pure opioid. It's an opioid agonist antagonist. So actually it is not as powerful as morphine. Morphine will have more chances of respiratory depression and postoperative apnea. And that's why we don't do any elective surgery before 50 to 60 weeks with post-gestational age. Okay. So usually I suppose that you people know about post-gestational age, the age of the birth age. It is actually if the baby is premature. So birth age plus post-conceptional age. Okay, so the weeks after, like for example, our baby born at 30 weeks, and now his extrauterine life is 20 weeks. So now his post-gestational age is still 50 weeks. Okay, so in premature babies we consider like that. So we should not have any elective surgery before 50 weeks at least. In some books you will find 60 weeks, because there will be more chances of central apnea. Okay, so you have to monitor the central. And with reference to, yes, thanks for reminding. I forgot to discuss anzulisis. Actually, they in different setups there will be different things, but just for your information, in international standards, they have mock, they have mock operation theaters or mock pre-anesthesia clinics where they show the things. Okay, so when the baby is looking at it, the baby will not be as unfamiliar before. Okay, this is one thing. The masks which we have are sometimes in good hospitals, the masks are cherry flavor or lemon flavor or strawberry flavor, so that is something too nice for them. Okay, otherwise you are giving actually midazolam usually orally, because in some hospitals where they are giving the pre-anxiolysis, they are using paracetamol and midazolam oral. Okay, and it is a slightly higher dose, 0.5 milligram per kg, up to maximum of 15 milligram of midazolam they are giving oral. Okay, and now I just recall when I was discussing about IV lines, I forgot to tell about EMLA. Okay, so just pardon me for that. There is one way to pass IV lines is a eutectic mixture of local anesthetic, which is lidocaine and prilocaine, and eutectic means it will melt when it is applied to the body, and the medication will be absorbed. Okay, so anxiolysis option is one of them, is this one, or you can give ketamine intramuscular. It will be helping because this is one way. Yes, in some babies they will cry even further, but if you are using a small syringe, maybe insulin syringe, you can poke quickly to have ketamine oral or IV. This is intramuscular, or we have fentanyl lollipops, which I have never seen. This is only theoretical that there are fentanyl lollipops, and even there is intranasal midazolam. I just heard, I think just read somewhere. Okay, so who has raised the hand now? Yes, Dr. Humera. And
Yes, sir. Gopal
Sir,
here, sir.
there is a question. Sir,
Hello.
can
just a
we?
second. Just a second. Just a
Sir,
second. Let him.
Gopal.
Yes.
Okay, sir.
Ask, please.
May I, sir?
Yes, please.
Yes, sir. I was talking about the sir ketamine. Can you share your experience about the ketamine? It's written in the books that you can give the ketamine 30 minutes before when you shift the patient in the OT. If there is the IV line is difficult. Have you sometime given, sir?
Yes, I give. There is no problem. The only problem is that secretions are increased. So sometimes you can mix atropine with ketamine and you give IV. Sorry, intramuscular. Okay.
IG, sir. IG, it's written IM or the IG, sir. The dose is written, sir, 2 mg. Isn't sufficient dose, or it's more than the norm average dose?
2 written is 2 milligram per kg, but usually even if you have given a little more time, even smaller dose work. Okay, but for that
Achha,
you
1
just
mg is sufficient. So, sir, how many minutes before we should give the IG ketamine? Either 30 minutes or more than 30 minutes?
For oral, it will be more. For IM,
No,
it
sir.
will be
What
what you are talking about, IM or oral?
IM, not the oral, sir. IM.
Okay, IM at least 10 to 15 minutes, at least.
Isn't sufficient, sir? Achha, at least, sir, because I had given, but patient was still awaking even after the 15 minutes. So
Okay,
I did wait for the 30 to 40 minutes, sir.
You might need, the absorption. It will be depending where you give. Okay, and was it diluted or it was undiluted? Because usually you should give undiluted. Okay.
Yes,
You
sir. I
should give
had given undiluted, not the diluted.
undiluted. Anyways, there are so many factors for absorption of medication from any site. Okay, so maybe there will be some other reason for development, but usually if you give 15 minutes before, usually you will it will not be an ideal patient is sleeping, but you will get something. Okay. Yes, Dr. Humera, your question.
Sir, we have fear that the child may have some congenital cardiac problem or not. How can we assess these babies for cardiac lesion or some problem?
This was the first thing which I discussed, that you will be asking whether the baby becomes blue when the patient the baby cry. So this will be one sign, and of course, if you have a history, you will send the patient for echo, for VSD, ASD, AVSD, this one PDA. Okay, if you are suspecting, if you have any other congenital anomaly, and even for example, if it's an elective case, it is, and but there are 1 or 2 congenital anomalies, it is advisable to rule out other congenital. It will be better to do echo. Okay, but it will be depending on the urgency of the surgery for which the patient is going. Okay, so just in this discussion we had a quick review with reference to, yes, another important thing is the NPO. So it is 2, 4, 6, 8. 2 hours for clear, 4 hours for breast milk, 6 hours for international food, and 8 hours for Pakistani food. Okay, like fatty meal is 8 hours, Pakistani food is 8 hours meal, it's never 6 hours meal. So formula feed is 6 hours. Okay, formula feed or normal light meal is 6 hours. And what about chewing gum? What about chewing gum? The babies are sometime having, even adults, they have chewing gum. How many hours for chewing gum? Yes, please.
4.
No, 6 hours. Okay, 4 hours is only for breast milk. Okay, mocha, what is mocha, Dr. Sagar? What is mocha? Please, can you tell? What is mocha?
Sir, I heard it somewhere that they use it as a pre-medication. It includes medalasam, ondansetron, ketamine, atropine. It's a mixture of some these drugs, but I have never seen it using somewhere. I just
Actually,
read it some.
actually, I tell you something. I am a big advocate of cocktail anesthesia. Okay, I tell this, and because I'm not in a setup where I can do any study, but actually I am combining, or I'm giving midazolam, ketamine, fentanyl, morphine, along with propofol and lidocaine. Okay, and also paracetamol. And if any NSAID, like we have here this lornoxicam, this is NSAID, so I will writing here NSAID. Okay, I'm usually trying to give it before induction in small doses. Of course, with propofol there will be muscle relaxant, but usually my aim is to give these medications, like in adult, for example, I will take 1 milligram, 25 milligram, 25 mics only, 2 to 3 milligram, 50 milligram. In any, even I have tried this with even 120 kg, use small dose and around 50 milligram of lidocaine and 1 gram of paracetamol, and around, according to any dose, whatever NSAID you are using. Okay, and with a higher dose of rocuronium, because we have rocuronium here. Okay, and slightly you can say 1 milligram per kg, around 1 milligram per kg. Okay, lean body weight. So I am getting a very good result, and after that either I give a block, any block, or usually I start dexmedetomidine. Okay, and if you don't have syringe pump, still if you have this 200 microgram per 2 ml of dexmedetomidine, okay, what I do, I take even 0.2 ml. So 0.2 ml will be around 20 mics. Okay, even 25 mics, I think. So I just put it in 500 ml, and I titrate the dose. I titrate the rate according to the response, because whenever you are using dexmedetomidine, okay, then you might expect bradycardia and hypotension. Okay, so I anticipate, and usually in adults I give glycopyrrolate anticipatedly. Okay, so the heart rate, if for example the heart rate is going down, so if it is touching 60, it becomes 80. Okay, so similarly there will be a lot of regimes like this. Maybe at some point of time, maybe I will try to have something documented about it. but that's what how I am doing these days. Okay. So propofol and ketamine
Sir,
together.
how to make lidocaine 50 milligram?
I'm sorry,
This is how much? Sir, how do you make lidocaine 50
Dr.
milligram?
Humera, please ask some questions which I like to answer. What do you mean by how to make? It is either 1% or 2%. If it is 1%, it is 10 milligram per ml. If it is 2%, it is 20 milligram per ml. So if you will take either 2.5 ml or 5 ml. What do you mean by how to make
Right.
it? What the rationale of this question? I have special relation with Dr. Humera, so don't mind it.
Sir, I
Because
mean,
because
sir,
Dr.
I
Humera,
mean
if you ask a
combination.
question, if you are sorry, what do you mean?
Sir, I'm asking in cocktail. How do you prepare this cocktail?
You can prepare in separate syringes. I do combine it, but never do it and never quote me. But I'm mixing it, nothing happens. I mix it and I give it. I prepare it just before when the patient, they are putting the monitor, I'm making I have just documented as a masala. The Arabs, even the people who are working with me, now they know this is Dr. Zishan's masala. Okay, I am taking in 20 cc, I'm mixing everything. Though please don't, you cannot quote it. It's you should never mix medications. I can never tell anyone to mix medication. But some of the medications we mix propofol with the lidocaine. We mix propofol with ketamine. We can mix it. But I have gone to a slightly advanced stage, because here if I'm using this masala, I'm getting very good result. Yes, please, because I am getting late. Yes, Oppo A12.
Yes, sir, I want to share my experience, sir. I have many times I have added in the cocktail, as you said, I ate diclofenac and the sir toradol in the cocktail, sir. 2 drugs. I get excellent response in the influenza.
No, you are talking about ketorolac.
Yes, sir, ketorolac.
Both ketorolac and diclofenac.
Sometimes, yes, sometimes both, sir.
Okay, no, because both of them are.
Both are NSAIDs, sir. Both are NSAIDs, sir. I know it, sir.
Okay. Anyways, you see,
Sir,
if you are not kidding. Yes, Tayyab, before last question before we finish. Yes.
Sir, please, I am against mixing two NSAIDs. What is
I am
rationale
also
behind this?
I am also mixing against mixing. but I am doing it and nothing happens. Okay.
You
Actually,
also do two NSAIDs together?
two NSAIDs together? No. Okay. I will not mix two NSAIDs together. I don't think so. I don't know. You see, the thing is that there should be, when you are doing a practice, you can do anything if you are not doing any harm. But I don't think so there is any rationale behind mixing these two medications. Behind mixing two medication in vitro, the problem is that sometimes there is some reaction which occurs by which the medication precipitate. Then you should never give it.
Oh.
Otherwise, if it is not precipitating, Bismillah ar-Rahman ar-Rahim, you can try. I am trying it and nothing happens. But of course, you cannot quote me and don't try to do it. Okay. That Dr. Zishan told, there are so many people. One of my teacher, he used to give 30 milligram. Can you believe? 30, I'm repeating, 30 milligram of bupivacaine, heavy marcaine in spinal. Can you try it? 30 milligram. Okay,
up to 21. Up to 21.
I have
3
given I have given up to 20. I give regularly. I am giving 20 milligram. Even people are looking at me like this. Oh, Dr. Zishan, what are you doing? But I am doing it regularly. I am doing it especially actually for TKR. And I make the patient lateral for at least 15 minutes, despite surgeons. So I just try to start discussion on anything, and I am just requesting them. Now they have understood. Before, when I was trying to do it in the early days, they were getting very angry that what are you doing? Okay. But I give 20 milligram bupivacaine, I make the lateral, and the effect, even if they are proceeding up to 4 hours, the block is maintained. Okay. So this is something new. I don't think so that there is any indication of mixing two NSAIDs. But if you are using in low dose, there is no problem. I again tell you that both of them are NSAID. Both of them are working as anti-inflammatory. The bottom line is that you should give it, because this is the concept of preemptive analgesia. Preemptive analgesia. Okay, when you have anything coming, any wind is any problem is coming, it is better to anticipate. Okay, so it is just like anticipation. So when the injury at actual tissue injury occurs, you already have given some anti-inflammatory to bribe the system, so inflammation will not occur. Okay, yes, please, last comment, because I am getting late. I have to read something.
Yes, sir. You said that, sir, you add the 20 milligram of the bupivacaine for to prolong the effect, sir.
No, 20 milligram spinal. I'm talking about
Yes, sir.
subarachnoid.
Spinal for to prolong the, sir, effect, sir.
Yes.
As you said in the TKR, sir, have you any experience, sir, of the dexmedetomidine intrathecal with
Actually,
the bupivacaine, sir?
Actually, I don't have experience because I don't have the preservative free. Okay.
All right, sir.
I have not tried it because we don't have documented preservative free preparation. Okay, because the concept is that people are mixing fentanyl, but in my opinion, it will not prolong. It will only improve the quality of the block. So if you want to improve the duration, fentanyl will not work. Yes, morphine will work, because morphine is like, it is just like it is strangulated in the space because it's least soluble. So it will remain in the CSF for a longer time, much more time, because fentanyl is just a funky medication. It will not never.
Dexmedetomidine. Dexmedetomidine, does it increase the block, sir? Increase the duration of the block, sir?
Yes, definitely it increase the duration of block.
So, can I ask the question, why you give the, sir, 20 mg of the bupivacaine? Why not you add the dexmedetomidine in the, sir, 15 mg bupivacaine?
I told you I don't have preservative free.
All right, sir.
Okay, that's the reason. But of course you can give it. Okay, you can give it.
I give it, sir. I give it, sir.
You should give it. It's a very good medication. Okay. So all of you, thank you very much. So inshallah, we will come tomorrow with some new topic. Bye bye.